Come funziona il farmaco canrenone e perché oggi è importante anche a livello cardiovascolare? Se ne parla durante l'edizione 42esima del congresso Conoscere e Curare il Cuore e noi ne parliamo con Paul Tang. How does canrenone work and what about the transition from diuretic to a key drug in the management of cardiovascular diseases?
Well, first of all, thank you very much for the opportunity to talk about mineral receptor antagonists, in particular carrinone. The way carrinone works is it's actually a metabolite of spironolactone, which is much better known in the international community. Carrinone is actually available in certain countries, used clinically, and certainly here in Italy. So when it is a metabolite, when you take spironolactone, it gets metabolized into carrinone. In fact, carrinone is more potent, meaning that the same dose has higher effect on competitive inhibition of mineralocorticoid receptors. So it prevents signaling through the mineralocorticoid receptors. And it's been shown for many years that it's good for patients with heart failure, although people think that it is more better known as an antihypertensive from its diuretic effects because people can see once they take carrinone and other mineralocorticoid receptor antagonists, they go to the, make urine, go to the bathroom, and they think that's the only way it works. But what is less appreciated is it actually works on mineralocorticoid receptors in many organ systems. And for us, it's the heart, and it actually improves cardiomyocyte and cardiac cell survival and reduces inflammation and stress. And I think that's probably some of the ways in which it actually helps patients with heart failure.
What could be the role of canrenone in cardioplegia for cardiac protection during surgical procedures such as heart transplantation and valve surgery?
Great. So that's a terrific question. In surgical procedures, the thing about carrinone is it's a water-soluble drug, unlike its siblings, spironolactone or spleronone or finerenone. Those are not very water-soluble. So you can actually add the drug directly to cardioplegia or another preservation solution in the setting of heart surgery, and it will dissolve quite naturally in there without needing a solvent, which is yet another substance. But what it does let's talk first about non-transplant heart surgery. But what we've shown is it probably has an effect in patients who take mineralocorticoid receptor antagonists prior to heart surgery. They have a lower incidence of a post-operative atrial fibrillation, which occurs in about 30 to 40%. And it reduces that by about 40%, which is significant. And importantly, it also reduces the long-term development of more chronic or paroxysmal AFib. And at 6 years, you see a similar reduction by about 40% of development of long-term AFib. If you think about it, that's a huge improvement and reduction in morbidity. And next, in transplantation, there's a huge opportunity there in terms of prolonging the allowable preservation time of hearts. Currently, with ice, you have about 4 hours, but what we've shown is you can actually extend that well out beyond. And in combination with more newer preservation methods like continuous cold perfusion, you can actually increase that allowable preservation period for hours in the teens. 18. We showed data in the 18-hour range showing that it works. It makes the heart contract well or function well at that time point.
How could canrenone contribute to the management of atrial fibrillation in patients with heart failure?
So in heart failure, there's a lot of data, particularly in patients with heart failure. And that's the same with development of post-operative atrial fibrillation. It works really well in patients with underlying heart failure in reduction of post-operative atrial fibrillation, but also in the non-surgical setting. It reduces new onset of atrial fibrillation. It reduces the burden of atrial fibrillation. So the times that people get admitted to hospital for a fast heart rate, it's less, and also improves survival in that setting. So it's got huge potential. I don't think that's really well appreciated in the cardiovascular medicine space, and so I think there's a huge opportunity to reduce the burden of this arrhythmia.
What are the future prospects for the use of canrenone in donor organ preservation and in reducing rejection from after transplantation?
Yeah, so there's a huge shortage, as many would know, mismatch between number of donors and the people who need it. So worldwide, there's been over 5,000 heart transplants a year, but really there are about 50,000 patients on the list. We're just saying people on the list, not necessarily people who need it. There are probably a lot more who need it. So there's one way that we can improve. I talked about prolong the ischemia time and allowable preservation time, improving matching, so you're not wasting organs. But also the other way of reducing morbidity and increasing the benefit is to make these heart transplants last longer. The median graft survival is about 12 years currently, and that's not very long if you think about it. In terms of young people, particularly young people in the 30s or 40s who have heart failure, that's not very long. They're only 40 something, 50 before they're looking at another heart transplant. So by using mineralocorticoid receptor antagonists like carinone, those mineralocorticoid receptors are actually expressed in dendritic cells, macrophages, all the cells in the donor that present antigen to the recipient immune system. We're not exactly sure how carinone affects that, but I would bet that it does. Or mineralocorticoid receptor antagonism, it does. And I'm hopeful that in the future we can learn more about it and maybe add that as an additional benefit and just reduce the burden of heart failure.